Assalamu alaikum. My name is Dr. Rashid. I hope you are all fine after the summer vacation. Unfortunately, we can't see you physically in the college because of the COVID-19 pandemic, and we hope sincerely that after this pandemic we will restart the lectures and the clinical training in the hospital and college. Meanwhile, we have to continue online teaching, and today I am going to discuss acute diarrhea. My mobile number is 0300 8440973, and my WhatsApp number is same 0300 8440973, and my email address is rzia56@hotmail.com. If you want to ask anything regarding pediatrics, any question regarding today's topics and the previous topics, please feel free to phone me or send email or WhatsApp me. I will be delighted to give you the answers as soon as possible. Today we are going to discuss acute gastroenteritis, which is one of the common problems in summer in Pakistan, and we see a lot of cases of acute gastroenteritis in summer, and lot of cases of upper respiratory and lower respiratory tract infections in winter. As far as the diarrhea is concerned, it is a second leading causes of all death worldwide, and is one of the most common causes of morbidity and mortality in children worldwide. It accounts about 30% of hospitalization in children in Pakistan, and about 9 to 10% of hospitalization in children less than 5 years old in United States. The definition of gastroenteritis is if you have 3 or more loose or watery stools per day, then you can label as having diarrhea. Or the other definition is that if your stool weight is excess of 200 grams per day, then you are labeled as having diarrhea. The other most important thing is if there is an alteration in the normal bowel movements characterized by the decreased consistency and increased frequency. So two things are important in the definition. One is decreased consistency and the other is increased frequency, and the duration is less than 14 days in acute diarrhea. This is a arbitrary definition because if you have diarrhea more than 14 days, we labeled is as chronic diarrhea. So for acute diarrhea, the duration must be less than 14 days. As far as the epidemiology is concerned, you roughly get 2 episodes per person annually in the general population, but in children it is 2.5 episodes per child less than 3 years old annually, and 5 episodes per year for children less than 3 years old, and in daycare, because you usually get cross infection in daycare where there are other children, so you have more episodes of diarrhea if you attend a daycare, nursery, or in a school. We have 2 peaks of diarrhea. The major part is in summer, but we have a second peak in winter when we see a lot of cases of gastroenteritis. As far as the etiology is concerned, we have a viral etiology in which 70 to 80% of the infectious diarrhea in the developed country is due to viral infections. Bacterial are 10 to 20% of infectious diarrhea, but responsible for most cases of severe diarrhea. Bacterial diarrhea are usually more severe as compared to the viral one, and then there is a third cause, which is a protozoal, and it counts for the less than 10% of the etiology. So the most common cause of diarrhea in children is viral in etiology. And out of viral etiology, there are different types of viruses. The most common virus responsible for diarrhea in children is rotavirus. The other viruses are the norovirus, also called norvo-like. The third is enteric adenovirus, and the fourth is astrovirus. Rotavirus is the most common cause of diarrhea and is the leading cause of hospitalization for diarrhea in children, most prevalent during the winter season, but we see also in the summer also, and it's the fecal-oral transmission and the viral shedding can persist for 21 days. So if a child is suffering from rotavirus infection, he is infectious to other children for the next 21 days because he keep on shedding the virus in the stool. It is an acute onset of fever followed by watery diarrhea, which the frequency of stool is 10 to 20 per day and can persist up to a week. This is the electronic microscopic view of the rotavirus. The second type of virus is norovirus. It is most common cause of diarrhea, which gives you outbreaks or epidemics. So if you see a lot of cases in a school or in an institution with diarrhea, so most likely it is an epidemic and it is usually due to norovirus. There are multiple modes of fecal-oral transmission. The acute onset of nausea and vomiting, watery diarrhea with abdominal cramps, and persist for 1 to 3 days. You see one time lot of cases of diarrhea in children with abdominal pain, nausea, vomiting and watery diarrhea, then most likely they are all suffering from norovirus. Mostly the rotavirus gives you infection in 1 or 2 children. Then this the enteric adenovirus is primarily affects children less than 4 years of age. Is the transmission is same as a fecal-oral, and the clinical picture is similar to the rotavirus, where you get fever and the watery diarrhea. Then the fourth variety is astrovirus, primarily affects children less than 4 years old and those who are immunocompromised. This is seasonal peak in the winter. Fecal-oral transmission, viral shedding can occur for several weeks. With astrovirus, you get fever, nausea, vomiting, abdominal pain, and diarrhea lasting up to 1 week. So the summary of the viral diarrhea is most likely cause of infectious diarrhea in children. Rotavirus and the norovirus are most common. Symptoms usually include low-grade fever, nausea, vomiting, abdominal cramps, and watery diarrhea lasting up to 1 week, and viral shedding occur for weeks after settling. Viral shedding can occur for weeks after symptoms resolve. Now, after the viral diarrhea, the next cause common cause of diarrhea is a bacterial in nature, which is there are different types of bacteria which can give you acute gastroenteritis, like Campylobacter, Salmonella, Shigella, Enterohemorrhagic E. coli, and Vibrio cholera. So we'll discuss one by one what are the different bacterial causes. Campylobacter is the most common bacterial pathogen which causes diarrhea in children, and they transmit it through the ingestion of contaminated food or by the direct contact with the fecal material. And the symptoms include diarrhea plus minus blood, abdominal cramps, can be severe, malaise, and fever. Usually self-limited and does not require antibiotics. This is the picture of the Campylobacter organism, which gives you a diarrhea, and it's one of the common causes of bacterial diarrhea in children. The next variety is a Salmonella, which is also most common in children less than 4 years old, and a peak in the first few months of life, transmitted via ingestion of contaminated food and contact with the infected animals like chickens. Symptoms include fever, diarrhea, and abdominal cramping. Antimicrobial therapy can prolong fecal shedding, but if the child is toxic and having severe fever, then we have to treat them with antibiotics because they then not recovered. This is the picture of the Salmonella. You can see the body and the tail of the Salmonella organisms. There are three varieties of the Salmonella: Salmonella typhi and the Salmonella paratyphi A, B, and C. Now the next variety is the Shigella, which is also transmitted through fecal-oral route. Symptoms include fever, abdominal cramps, tenesmus, and mucus stools with or without blood. Can lead to serious complication. Antimicrobial treatment shorten the duration of the illness and limits the fecal shedding. So in Shigella infection, the antibiotics are indicated in the early stage. Next cause is E. coli O157-H7, and transmission is via contaminated food and water, and the symptom includes a bloody diarrhea, severe abdominal pain, and sometimes fever, and the child is usually quite unwell and can lead to a serious complications like renal failure. Antibiotics have no proven benefit and may increase the risk of the complications. This is the picture of the E. coli. You can see their body, in which there are hairy and there are number of tails. Unlike the typhoid, there is only one tail. Then there is cholera, Vibrio cholera. There are two major biotypes of the Vibrio cholera that can cause diarrhea, or classical and etor. And there are two common serotypes of Vibrio cholera that cause diarrhea, are Inaba and Ogawa. Luckily, we have seen less cases of cholera. A few years ago, there used to be epidemics of cholera in Lahore, and used to get lot of cases of diarrhea, severe diarrhea with severe dehydration in children and in adults. But luckily now with the vaccine against cholera and the improvement in the living standard, we see very few cases of cholera in summer. The clinical features of the cholera: you will see the rice, watery stool, marked dehydration, projectile vomiting, no fever or abdominal pain, muscle cramps, hypovolemic shock, and scanty urine, because they pass less urine due to dehydration. This is the picture of the cholera vibrio. It is usually a comma shaped and gives you severe watery diarrhea, and the mortality is very high if you don't treat them at the right time. Now the summary of the bacterial diarrhea is that it can affect all age groups and the fecal-oral transmission often through contaminated food. So please avoid the contaminated food to having this problem. Typical symptoms include bloody diarrhea, severe cramping and malaise, and antibiotic treatment not always necessary. The antibiotics are usually necessary in Salmonella infection and in Shigella infections. As far as the history and physical examination is concerned, there are three main goals. Estimate the level of dehydration. I will tell you the different types of dehydration like mild, moderate and severe, and what are their presentation. Identify the likely causes on the basis of the history and clinical finding. Determine if additional studies and or medications are necessary. In the history, you will see the onset, frequency, quantity and the character. You will ask about the onset, frequency, quantity and the character of the diarrhea. Associated symptoms like nausea, vomiting, fever, abdominal pain, tenesmus, malaise. Recent oral intake from outside the house, because usually you get infection while you eating outside, like in restaurants and takeaways. Most unlikely you will not get any infection if you eat a homemade food. And what are the signs and symptoms of dehydration? You assess the level of dehydration. Physical examinations, the vitals are most important, and in vitals you check for the respiratory rate, heart rate, temperature, blood pressure and oxygen saturation, and you will get the fair amount of idea what is the condition of the child. You do abdominal examination to check if there is any abdominal distension, if the bowel sounds are present and not, or the level of dehydration. The presence of the occult blood is also very important in gastroenteritis. Sometimes you see occult blood, sometimes you see frank blood. And as I said, the signs of dehydration. As far as the lab evaluation is concerned, it mostly is unnecessary for children who present within 1 day from the onset of diarrhea, because mostly the lab investigations are normal, and it is the clinical examination which will give you the diagnosis and the type of cause of diarrhea. The warning signs and symptoms are the bloody diarrhea, high grade fever, severe abdominal pain, severe dehydration, or the comorbid condition when you see the deterioration in the conscious level. The fecal leukocyte followed by bacterial culture over and parasites, viral antigens. We check the CBC to differentiate between a viral and a bacterial infection when we see a high white cell count in bacterial infection, and we'll check for the urea and electrolytes to see the sodium and potassium and the calcium level, and also renal function to check the urea and creatinine, to check if there is any perirenal or renal failure. As far as the treatment is concerned, the most important treatment is a fluid replacement. As you know, you lose fluids from the body with acute watery diarrhea and vomiting, so you have to replace the lost fluid, and the fluids are given in the form of a oral rehydration solution, which we call ORS, or if the child is unable to swallow, or if he is not in a fully conscious state, then we have to give parenteral IV fluids. We recommend early refeeding against all the odds, because people are not used to give feeding to the child with gastroenteritis, which is not a advisable thing to do, because children are usually malnourished either before having gastroenteritis, or they become malnourished with gastroenteritis. So early refeeding is very important as far as the management of children is concerned. Sometimes we give loperamide or oral bismuth for adult, for older children, or zinc also, because that helps in the treatment of the diarrhea. And as I mentioned, there are few indications of antibiotics prescription, like in Salmonella or in Shigella. As far as the assessment of the dehydration is concerned, it is very important because it will change your management. So there are different types of malnutrition. First, for dehydration, which called mild, moderate, and the severe. In mild dehydration, the appearance is irritable and thirsty. The anterior fontanelle is normal and eyes are also normal. In moderate dehydration, the child is irritable and very thirsty. The anterior fontanelle is depressed and eyes are sunken. And in severe dehydration, the child is also lethargic and coma or unconscious, and the anterior fontanelle is markedly depressed and eyes are more sunken. In mild dehydration, the tongue is normal, the skin is normal, and the breathing is also normal. In moderate dehydration, the tongue is dry, the skin is slow to retraction, and the breathing is rapid. In severe dehydration, the tongue is very dry and furrowed, and skin is very slow retraction, and the breathing is very rapid due to acidosis, metabolic acidosis. In mild dehydration, the pulse is normal, the urine output is normal, and weight loss is less than 5%. In moderate dehydration, the pulse is rapid and low volume. The urine is dark due to concentration, and the weight loss is between 6 to 9%. In severe dehydration, the pulse is feeble or imperceptible. The urine is scanty, and the weight loss is 10% or more, and the blood pressure is also low or unrecordable. As far as the fluid replacement is concerned, if the child is conscious and no vomiting and mild and moderate dehydration, we usually give ORS. ORS come in the form of a powder form, where you have to make and put the whole packet of ORS in 4 glasses of water. It also comes in the form of a Pedialyte. There are different flavors of Pedialyte, like apple flavor, orange flavor, strawberry. So children like the Pedialyte more as compared to plain simple ORS. So you can try if the child is not vomiting or he is fully conscious. And you have to correct the dehydration in the next 24 hours. The composition of the oral rehydration salt is The ingredients are sodium chloride 3.5 gram per liter, trisodium citrate or 2.9 or sodium bicarbonate 2.5 gram per liter, potassium chloride 1.5 gram per liter, and the glucose is 20 gram per liter. The glucose helps in the movement of the sodium and the potassium inside the cells. As I mentioned, early refeeding is very important because the luminal contents help promote growth of the new enterocyte and facilitate mucosal repair, and early refeeding can shorten the duration of the disease. Lactose restriction is not necessary except in a very severe and prolonged diarrhea. I have seen children put on a lactose-free milk in cases where there is a history of diarrhea for 1 or 2 days, which is not recommended. Lactose restriction is only recommended in a very severe and prolonged diarrhea cases, not in a short duration of diarrhea. The lactose-free formula is not a normal milk, so it should be indicated only in the cases which really there is a lactose intolerance, not in every case of gastroenteritis. I usually not give any other medicine except the zinc, which is usually recommended, but sometimes in older children we can give loperamide and bismuth for reduction of the volume of the and frequency of the stools. As I mentioned, empiric antibiotic therapy generally not beneficial and can be harmful. Those with more than 8 stools per day, diarrhea, more than 1 week, volume depletion, immunosuppression or warning signs, then you can give antibiotic. We normally give third generation and cephalosporin, but it varies from the type of the cause of the gastroenteritis. The specific antibiotic therapy, obviously no need to give if there is a viral etiology. Campylobacter only if severe. Salmonella mostly if they have a high grade fever, then we give antibiotics. Shigella, there is an E. coli. In Shigella infection there is a proven benefit that you have to give antibiotic, and in E. coli not 157 it can be harmful. So only Salmonella infection and Shigella infections we recommend to give antibiotic therapy. Complications of watery diarrhea, as I mentioned, dehydration is the most important complication. You get electrolyte imbalance like hypokalemia, hyponatremia, hypocalcemia. It can give you a tetany, convulsions may be due to hypocalcemia or hypoglycemia, and also renal failure can be due to dehydration, pre-renal failure, or as a complication of the E. coli not 0157, which can give you hemolytic uremic syndrome. We continue with the complication. As I mentioned, we have electrolyte imbalances, convulsions, hemolytic uremic syndrome, mostly due to E. coli infection, leukomyoid reaction, toxic megacolon, where you will find the distension of the abdomen, protein losing enteropathy. You can get reactive arthritis and sometimes perforation of the bowel, especially in cases of the typhoid gastroenteritis. We have a oral cholera vaccine and injectable cholera vaccine. We'll give every year the cholera vaccine we used to give, but now since the cholera epidemic are no more happening, so we normally not give any cholera vaccine as a routine unless there is an epidemic. There is a vaccine also available for rotavirus, which we give to every child as a part of a EPI program. The oral rotavirus vaccine is an oral vaccine we give every child at 6 weeks of age and 10 weeks of age, because rotavirus affects most of the children under 6 years of age. Then the other is the typhoid vaccine, which we can give orally also. There are capsules available 1, 3 and 5 days. 3 capsules are given to protect having typhoid infection for the next 2 years. There is also an injectable vaccine available. They also protect a child for 2 years of age. So you have to for 2 years, and so you have to give after every 2 years Salmonella vaccine, either orally or as injectable. As you know, the most common cause of diarrhea is a fecal-oral route. So, and the most important thing which can give you infection is if there is a polluted drinking water. So please always either boil the water for 10 minutes, then it becomes safe for drinking, and always take food from home made, and try to avoid the food from outside or also take away, because it gives you infection. So if you want to eat fruit, always wash them, peel them, and then eat them. Always boil the water for 10 minutes. Hand washing is very important, because hands are the carrier which takes you the infection into your mouth. And as we know nowadays, the importance of hand washing is so important to avoid COVID-19 infection. Proper sanitation is also important, because we have seen that there is a drinking water pipes are mixed with the sanitation pipes, and then there is a infection in the drinking water, and that can spread into all the community. Also, there are carriers of the typhoid fever which needs to be treated. So please, if you examine the stool or the typhoid test for all your food handlers, especially cooks in the hotels, restaurants and at home, that will protect you from having typhoid fever. Thank you very much. I hope this will improve your understanding of acute gastroenteritis and what are their signs and symptoms, and how we can manage and the gastroenteritis, and also how we can have a vaccine against different types of organisms. If you have any question, please, my mobile number is 0300 8440973. My WhatsApp number is same, 0300 8440973, and my email address is rzia56@hotmail.com. Please feel free to ask me any question regarding this lecture or the previous lectures, or any question related to pediatrics. I will be more than happy to answer all your questions as soon as possible. Thank you very much.